Hi, welcome to Oncologic Neuropathology, Part 2. If you haven't watched Part 1, which is the overview of brain tumors, a PowerPoint presentation, it's highly recommended that you do that. But let's jump into the cases. Here's unknown case number 1. Just from the gross examination, you can see this does look like cerebral cortex. This is the gray ribbon. Here's a sulcus. This is probably white matter. Here's the gray-white junction. All right, if we go up to higher power, you can see clearly the cortical ribbon as well as the white matter are very hypercellular. Let's have a look at the white matter. And we go up to high power, diffuse infiltration clearly of the white matter and the gray matter. The next thing we want to take a very close look at is the cytology. Now you'll notice that a lot of the cells are surrounded by cleared cytoplasm, perinuclear halos, and that might suggest or certainly can suggest oligodendroglioma. But the differential here is astrocytoma and oligodendroglioma. And if you look at the number of cells that have elongated nuclei, and there are a lot of these, and what that suggests is this is probably going to be an astrocytoma. In the old days, we might have called a tumor like that mixed oligoastrocytoma, but we know that the majority of those, probably 75–80%, are molecular astrocytomas. So you're going to be looking very closely for these elongated nuclei, pleomorphic nuclei. Let's follow the tumor as it infiltrates the overlying cortical ribbon. And again, as we go to higher power, we can see that many of the cells have this elongated shape. That's an infiltrative morphology of astrocytoma. So all of the cells you're seeing here really saying diffuse astrocytoma. And let's move all the way out to the pial surface. Here's a sulcus. And what you're seeing is this is actually an expanded subpial space. With the tumor cells infiltrating it, and they're in the molecular layer. That is a classic secondary structure of Shearer. So this is a diffuse glioma. The cytologic features are those of astrocytoma. We would have to confirm that, the differential being diffuse astro versus oligodendroglioma with molecular testing. And the first thing that we do is run immunohistochemistry for mutant IDH1 or 132H mutant protein. And if the tumor cells light up, the diagnosis is diffuse astrocytoma, IDH mutant, game over. If they don't, then we would have to pursue it with either PCR and probably other immunostains. So the answer to the diagnosis of this case was actually given on the pre-op imaging, and the pre-op imaging showed T2 flare mismatch, which was strongly almost 100% positive predictive value for diffuse astrocytoma IDH mutant. All right, and if you don't know what the T2 flare mismatch sign is, then review part 1. Okay, let's move on to the next case. Now this is very similar, unknown case number 2. Again, it looks like cortex and white matter, very hypercellular, microcysts. There's one difference here. We see prominent calcifications, and the calcifications are in the cortex. So if you were to follow these, look at the shape of the calcifications. They follow the cortical ribbon. That would have shown up as gyriform or curvilinear calcifications on the preoperative CT and MRI scan, gradient echo, susceptibility weighting, etc. That, in the context of the diffuse glioma, very suggestive of oligodendroglioma. So let's go up to high power, and the next thing we want to do is look at the cytology, and indeed, these cells are very round, very monotonous. In contrast to unknown case number 1, which was the astrocytoma, all of these cells are rounded, monotonously rounded. We're not seeing any of the elongated or slipper shaped nuclei. Based only on H&E, this would be oligodendroglioma, NOS, not otherwise specified, because you have to add the NOS if you do not perform the molecular testing. In order to call this tumor oligodendroglioma, IDH mutant, 1p19q co-deleted, which is the most precise WHO 2016 diagnosis, we have to evaluate both the IDH1 and IDH2 mutation status, and we do that initially with simple immunohistochemistry for R132H mutant protein, and for co-deletion of 1p and 19q. And there are a variety of methodologies for doing that. FISH is the most common, even though least specific. All right, let's move on to case number 3. And what you see here, the dead giveaway, and especially for board exams, if you look at these serpiginous, which just means curving, winding, sort of geographic areas of necrosis. And the borders of necrosis are hypercellular with respect to the rest of the tumor. That is called necrosis with pseudopalisading, or the short lingo is pseudopalisading necrosis. And another key feature that we see here, if you look at the blood vessels, notice there's a fibrin thrombus in this vessel. Another fibrin thrombus here. Intravascular fibrin microthrombi in a glioblastoma are strongly correlated with IDH wild type genotype. Another key feature that we see here, here's necrosis, pseudopalisading. These cells would be hypoxic. They would be secreting VEGF, vascular endothelial growth factor, into the environment, which would stimulate the proliferation of adjacent capillaries. And sure enough, look at this beautiful vascular proliferation. That is another hallmark feature of glioblastoma. Now, currently, right now, under WHO 2016, glioblastoma can either be wild type or IDH mutant or NOS, not otherwise specified if you don't have any data. You can diagnose it just off of these key histologic characteristics. Just a heads up, for the forthcoming 5th edition of the WHO classification of brain tumors, we'll probably be calling it WHO 2020 because it should come out before the end of this year. We are going to change the nomenclature of IDH mutant diffuse astrocytomas, and the 3 diagnoses will be astrocytoma, comma, IDH mutant, comma, WHO grade 2 or 3 or 4. So if this particular glioblastoma is IDH mutant, proven by either immunohistochemistry for IDH1 or 132H mutant protein, or if we have to reflex to non-canonical IDH1, IDH2 mutations through PCR, next generation sequencing, or profiling of any kind, then the diagnosis would be under the forthcoming 5th edition, astrocytoma, comma, IDH mutant, comma, WHO grade 4. All right, that's a heads up. It almost certainly will not show up on the boards for this year, but it's something to be aware of in the future. All right, and again, all of this was beautifully, if I do say with all humility, beautifully covered in part 1 of the lecture. So have a look at that if this does not sound familiar. Okay, let's move on to the next case. Multiple fragments of tissue going up to higher power. And the first 2 things are catching your eye. Let's just stay right on this field. The first thing is you see spindle-shaped areas. Those spindle-shaped areas look a little bit like pilocytic astrocytoma, elongated bipolar cytoplasmic processes, and interspersed between these elongated glial cells are nests, like here and here, of other cells that have, here, let's go up to higher power. There we go. Prominent nucleoli, a copious cytoplasm, Nissl substance. These are clear ganglion cells. Here's another great area. We look at this. These are clusters of ganglion cells in conjunction with the spindle pilocytic-like background, that component. This is ganglioglioma, classic ganglioglioma. How might we have suspected ganglioglioma before we even looked at the histology? If we had looked at the pre-op imaging. In the pre-op imaging for gangliogliomas, the tumors are always circumscribed, so sharply circumscribed. Frequently, they have a cyst. So this would be the classic cyst with contrast-enhancing mural nodule. Sometimes they're just solid. Sometimes they're multicystic, but they're always circumscribed. And the major age demographic is young adult. And the major anatomic location is temporal lobe. Now, of course, they can occur in older individuals. They can occur certainly outside the temporal lobe, frontal lobe, etc. But all of these features will help you so much if you behave as a physician and know all the clinical information. I have other lectures on that we could talk about. Remember, BRAF V600E is the most common driver mutation for ganglioglioma. So this was a nice classic case. All right, moving on to the next unknown number 5. And I really like this case. Let's go up to higher power. All right, at first blush, this looks very similar to the ganglioglioma we just saw, in that you have these large epithelioid cells with copious eosinophilic cytoplasm, and the nuclei have prominent nucleoli, suggesting ganglion cells. And I think if we were to search around in this specimen, you might find some areas which are a little more spindled, and you might think ganglioglioma. And that is a common misdiagnosis for this case. In fact, what this is subependymal giant cell astrocytoma. Wow. If all you have is the H&E, and you guys attempted this only on the H&E, if you are a neuropathology fellow or a neuropathologist, there is a gestalt that SIGAs, subependymal giant cell astrocytomas, have, that basically they declare themselves. And the gut feeling, the gestalt feeling is, I bet this is a SIGA. And what's the first thing you do if you think that? Oh, you go to the pre-op imaging. Because what separates SIGAs from gangliogliomas and gangliocytomas and gametophytic astrocytomas and anaplastic astrocytomas, which they can mimic? What separates them? It's the anatomic location. SIGAs are not in the parenchyma of the brain like all of those other entities in the differential diagnosis. They are in the ventricle. So this tumor absolutely would be in the ventricle. Now, if you look at this tumor, just the histology first, and it is screaming to you, I bet this is a SIGA, then you can see in your mind, you're actually seeing the pre-op imaging. You're seeing an interventricular tumor, most commonly in the lateral ventricle. That's why I say that pathology is imaging. Imaging is pathology. It is so powerful. All right, classic SIGA. All you have to do is think about it. And if you think about it in the differential, you look at the pre-op imaging, etc. Now, by the way, you know, I'm sure everyone knows that SIGAs are associated with tuberous sclerosis, but guess what? When you're called a frozen section, most of the time you will not have that history. This will be an initial presentation, and you're just going to have to include it in your differential diagnosis. And most commonly, it's going to be a child or occasionally a young adult, etc. And you will be the one that may say, you know, this is subependymal giant cell astrocytoma. We should look for stigmata, all right, physical exam, etc. Okay, moving on to the next case, unknown number 6, and we go to higher power. Wow, look what's catching our eye. This is wall-to-wall Rosenthal fibers. Remember the differential diagnosis by etiology, by pathogenesis for Rosenthal fibers that we talked about in part 1? All right, reactive Rosenthal fibers, by far the most common etiology around hemangioblastoma, around craniopharyngioma, around cysts like pineal cysts, etc. That would be reactive Rosenthal fibers. Neoplastic Rosenthal fibers, pilocytic astrocytoma, pleomorphic xanthoastrocytoma, ganglioglioma, those 3 entities. And then genetic metabolic, genetic disease, that would be Alexander disease. All right, now in this particular case, we're going to look around, and what we're going to see amidst as we survey different areas is clearly this has a glioma look to it. It's pilocytic. You see these elongated nuclei in an area like this, bipolar cytoplasmic processes. This is pilocytic astrocytoma until proven otherwise. Here's another indicator of chronicity. See the sclerotic hyalinized blood vessels? That's usually an indicator of chronicity, that the tumor's been there a while, that it's going to be a lower grade tumor. And the microcysts, again, a classic feature of pilocytic astrocytoma. Again, as long as you thought about it in your differential, all you have to do is go to the pre-op imaging. Typically, it's going to be circumscribed with a cyst or multiple cysts or solid, but always circumscribed. Pilocytic astrocytoma. All right, moving to case number 7. Wow, we don't have to get very far into magnification at all when you see densely cellular area, the red blood cells or blood vessels, and what you're seeing is clearing or anuclear zones around the blood vessels, and that is classic perivascular pseudorosettes. We go to higher power. Ependymoma, by far, the #1 entity on your differential diagnosis. Now, there are a whole host of brain tumors that can show perivascular pseudorosettes. A rosette-forming glioneuronal tumor has perivascular pseudorosettes. All right, now they are synaptophysin positive, not GFAP, but that's just one example. Papillary meningioma has perivascular pseudorosettes. The endocrinoid perivascular rosettes of pituitary adenoma can mimic ependymoma if you didn't know better. That's a really nice unknown to give. But this tumor is screaming ependymoma. Notice that it's solid. One of the first things that you should do when you're examining a slide that is solid tumor in the brain, solid tumor, try to find an area of normal brain and look at the interface. And we have an area like that right here. So here's brain, and you can see this is totally uninfiltrated normal brain at the periphery. And then we have this very, very tight, short zone of infiltration. That's great for the border of ependymoma. Relatively circumscribed tumors, treatment is gross total resection. All right, let's move on. I think that was a pretty easy one. All right, next case, higher power. Well, it's a little bit similar to the case we just saw in that you see blood vessels and these anuclear zones, and the cytology of the cells, oval cells with delicate salt and pepper, granular, stippled chromatin pattern. That looks like ependymoma, but the perivascular spaces have mucin, and there are also microcysts with mucin. All right, the first thing that you should think of with all of this mucin and ependymal features is myxopapillary ependymoma of the phylum Terminale, which is located in the lumbar cistern. Rare cases can be elsewhere. Myxopapillary ependymoma, that's going to be the diagnosis. We're following a theme. All right, moving on to unknown case number 9. Go to higher power. Multiple fragments, but every fragment of this tumor has a pattern. What's the pattern? Let's stay right here at this magnification. You see lobules, big lobules like this, this, this. So here are 1, 2, 3 lobules. And then as you look within each lobule, there are clusters of cells within the lobules. But the dominant component of this tumor is the finely fibrillar matrix in between very bland nuclei. Again, compact tumor, no brain parenchyma. If you wondered their brain parenchyma, you could run a neurofilament immunostain. Look for entrapped axons. Again, this tumor is classic subependymoma. Most common location, lateral ventricle to the foramen Monroe and fourth ventricle, blocking the outlet foramina, leading to obstructive hydrocephalus. Third most common location, spinal cord, where they cause symptoms early because of the the real estate where they're located at a small size. Classic subependymoma. All right, moving to the next case, unknown case number 10. Now, if you had started with this case, and even now, you might be thinking, I wonder, this would be mean, if they put in 2 oligodendrogliomas, because these cells are really round, really monotonous. They don't particularly show the fried egg artifact, the cleared cytoplasm, but oligos do not have to do that. They have this delicate branching, so-called endocrinoid or chicken wire vasculature. They can have microcalcifications. You might be thinking oligo, all right? But in this particular case, how could you separate it? 2 ways to separate this tumor. Number 1, it's in the ventricle. This is central neurocytoma. And number 2, if you even suspect it, you simply run GFAP and synaptophysin. Central neurocytomas are strongly synaptophysin, in contrast to ependymomas, will not have that degree of synaptophysin positivity. Here's another clue. Look around at all the fragments. Can you find infiltrated brain parenchyma? Oligodendrogliomas are diffuse gliomas. They infiltrate the adjacent brain parenchyma. You're not seeing any parenchyma here, all right? Now, sometimes you will get the adjacent brain, typically from the septum at the foramen Monroe. That's where they originate. You will get the adjacent brain. It will be a very short margin. You're not going to find infiltrated neuropil. You're not going to find secondary shear structures, infiltrated cortex, etc. That is another clue. It was actually mean to have all of these cases with no clinical history, but you know what? It helps you to develop an eye for the very fine details of the different tumors. And I tell you, it's so important to point out the importance of the pre-op imaging. If this case even seemed challenging to you in the least bit, it's because you did not have the pre-op imaging. If you had known that this was a significantly sized mass in the lateral ventricle at the foramen Monroe, extending into the third ventricle, obstructing the foramen Monroe, causing obstructive hydrocephalus, the first 10 things on your differential would have been central neurocytoma. Pre-op imaging, absolutely critical. All right, moving along to case number 11. We go up to higher power. This is a clear small round blue cell tumor. It would be the typical differential that everyone is very familiar with from systemic organ pathology. Small round blue cell tumors in the brain. PNET was old name. If this is posterior fossa, this is medulloblastoma. And we talked very briefly but very deeply about medulloblastoma in part 1 of the lecture. You can classify it based on morphology. This would be classic type or the patternless pattern, just sheets of cells. Sometimes, you may see homocyte rosettes in this pattern, but the neuro-oncologist, pediatric neuro-oncologist, and adult neuro-oncologist, for the second peak of medulloblastoma is between the ages of 20 years and 40 years. Every neuro-oncologist wants to know the molecular signature, and we can use immunohistochemistry to do that, which was reviewed in part 1. So bottom line, small round blue cell tumor. This particular example was from the cerebellum, medulloblastoma until proven otherwise. But you must run INI-1 to rule out atypical teratoid rhabdoid tumor. It's a good idea to do that on every tumor that you suspect to be medulloblastoma in the cerebellum. That's a good lesson. All right, moving to case number 12. And again, up to high power. It looks like, at first blush, again, another small round blue cell tumor. But this one does not look as malignant. Number one, there are no mitotic figures. There's no apoptotic bodies. Apoptotic index is very low. And then the cells are very bland looking. This is pituitary. This is a pituitary adenoma. In fact, it's probably, I think, an ACTH adenoma because you can see Crooks-Hyland change. See the ring here? There's another ring right here. Now, one of the things that you will become, or I hope that you're very used to doing, is in functional pituitary adenomas, ACTH and growth hormone, you really should be running, in addition to the full panel of the 6 pituitary hormones, CAM 5.2 for keratin. And what you're looking for is fibrous bodies. The fibrous bodies usually will indicate an aggressive tumor, and the CAM 5.2 will also beautifully stain these Crooks-Hyland, the Hyland rings. You get bonus points if you identified the Crooks-Hyland in this particular case. Again, the principle is you must perform on every pituitary adenoma, regardless of the serum status, the levels. You should run all of the hormones, pituitary hormones, and it is a good idea to run CAM 5.2 as well to classify. All right, moving on to unknown case number 13. And for this one, we picked a beautiful Simonis meningioma. Again, the key here, a quick question. Let me ask you a quick question. How the person, I'll just say person who grows this in, it could have been the attending pathologist, it could have been a fellow, it could have been a resident, it could have been a PA, could have been a histotech. What was the big mistake that the grossing person made? This had to have been dense on CT scan and then probably MRI, gradient echo, susceptibility weighted. There's a Simonis meningioma with a high burden. They had to have known it's calcified. When the person cut it in, as you run your scalpel through this tumor, it would have been crunchy. The big mistake is not running it through decal. Now have a look at this. Anyone ever seen any of Peter Berger's textbooks? Would he have a figure like this with all these just crunched out, hideous looking Simoma bodies? No, they would look beautiful, right? Why? Because Peter Berger puts the specimens, or his fellows put them through decal, and that's how you get the group. So bottom line, here's a lesson for the trainees. If you have a calcified tumor, even though it could be processed, it could be cut, as in this case, if you decalcify it, you're going to get a much better look. Now, the reason why that's important is that 85% of meningiomas of all of the 13 morphologic subtypes are WHO grade 1, but you have to do your due diligence and look for mitotic figures and necrosis and all the other things. And a Simonis meningioma absolutely can be grade 2 or atypical based on mitotic index. So it's incumbent on you to do your due diligence, don't get sloppy, decalcify, and look for mitotic figures. All right, moving on to the next. Again, I hope this was an easy case. This is a classic craniopharyngioma, but craniopharyngioma, that diagnosis, if that's what your final, you get a 50. On a scale of 0 to 100, a 50 is an F. Now, it's much better than a 0, which would have been if you didn't know what it is at all. But unless you said adamantinomatous craniopharyngioma, right, then you only get a 50. The reason is adamantinomatous and papillary craniopharyngiomas, they look very different on morphology, and more importantly, they have completely different molecular drivers. Beta-catenin mutation is the driver for adamantinous craniopharyngioma, and BRAF V600E mutation is the driver for a papillary craniopharyngioma. All right, you see all of the classic features in this particular case. Let's just go back to lower power. I like to go out here, all right, into the surrounding brain parenchyma. Sometimes this is all you will get. Look at this one nest of epithelium, but you see the peripheral palisading, and look at this whopping reactive Rosenthal fiber proliferation, generation formation out here. And that bespeaks to the long-standing nature of the craniopharyngioma, very slow growing. The real hallmark feature is wet keratin, these keratin whorls, wet keratin. Here's one right here. Let's zoom in on that. There's wet keratin. Occasionally, you'll get an example where a small biopsy from the periphery, maybe the craniopharyngioma has ruptured, and all you will see are these ghost cells of the wet keratin nodules in the appropriate context. That's going to be diagnostic of adamantinomatous craniopharyngioma. Beautiful example. Again, the driver, beta-catenin mutation. When one other really quick thing, when you run beta-catenin and BRAF V600E on these specimens, the beta-catenin is going to show beautiful membranous positivity in all of this epithelium, but that's a negative immunostain, right? You know that from other contexts. It's going to be the cellular whorls and the edge, the palisading edges, that will show the strong positivity in the nuclei of a subset of cells. It's usually a minority of nuclei that show the aberrant intranuclear translocation of beta-catenin, but they will be there if you have a large enough example. Okay, moving on to the next example. Next case, this is unknown case number 15, and what you're seeing again are multiple fragments of non-keratinizing squamous epithelium. Now here's the thing, if you look at this, you might say, look at the periphery here, you might say, you know, that looks like peripheral palisading, and the interior is breaking apart. That looks like stellate reticulum. So I think this is an adamantinomatous craniopharyngioma because I see peripheral palisading, I see stellate reticulum. Well, what this is a papillary meningioma that is mimicking adamantinomatous in those two features, but only those two features. What did we say was the morphologic hallmark of adamantinomatous? The wet keratin nodules. There is no keratin in the specimen. All you see is non-keratinizing squamous epithelium and then all these fibrovascular islands in between, multiple nodules. And of course, you could run BRAF V600E, which would be positive, diffusely positive cytoplasmic, and you should see no intranuclear beta-catenin translocation in papillary craniopharyngioma. Okay, moving on. The next case, this is actually our last case, multiple nodules or lobules at low power, somewhat reminiscent of the subependymoma, but we go to higher power. And the two features we see are the myxoid matrix and these cords, nests and cords of cells, which are highly vacuolated. Those are the physalliferous cells. The etymology of physalliferous is quite beautiful. Physalia is the genus of Portuguese manowar, you know, the big bubble floating on the sea. It means bubble. So that Physalia is bubble. Ferrous, the last part, ferrous or forous, means carrying, like electrophoresis, charge carrying. We use electrophoresis to separate proteins, other charged molecules. So the physalliferous cells are bubble-bearing cells. Beautiful etymology. This is chordoma. How would you prove it's chordoma? Well, you would run immunohistochemical stains. And historically, the three stains that would be run are typically two epithelial stains, pankeratin, cytokeratin, keratin cocktail, and EMA, epithelial membrane antigen, so two different classes of epithelial markers, and a neuropress marker, S100 protein. And classically, chordomas would be positive for all three. Sometimes the S100 can be very iffy. Many times it's only cytoplasmic, not nuclear. Not nuclear, that is fine. It can be the weakest of the three, but in the context, then that's diagnostic. But in the year 2020, you really only need one marker, and that's brachyury. Very robust, strong marker, stains the nuclei, intensely positive, virtually all nuclei. You will always have the capillary endothelial cells and lymphocytes as internal negative controls. Well, that is a very quick review of the unknown cases. I hope you did well. If you had trouble with these, I think this would be a great time to go back and review the introductory PowerPoint lecture, because I covered the key features of all of these tumors in quick but critical detail. And I think these are the major entities, 16 major entities that are likely to show up in the boards. Thank you very much for watching the lecture. Follow me on Twitter, Greg Fuller, MD, PhD. I post unknown cases and other things. Thank you very much. This concludes the lecture.